And with this background, so I want to conclude few things which has universally accepted. So all pre-surgical workup should include, as morning as rightly mentioned, is both the CECT and PET scan, and of course endoscopy and endoscopic ultrasound to know the nodal stasis in the mediastinal area, and of course the fitness for surgery. So there is a no controversy for the management of Siewerts. So it's very documented that Siewerts will be treated like a esophageal cancer. So esophagectomy will be a trans-thoracic esophagectomy or trans-hiatal esophagectomy in selective cases. I think that will be covered in my next talk. So coming to the trans-thoracic, compared to Ivor-Lewis versus McKeown esophagectomy, so there is no significant difference of overdoing the lymphadenectomy. So the standard of care now is Ivor-Lewis thing. And the studies which compare the trans-hiatal esophagectomy, there is initially the median OS and DFS and quality adjusted survival is not so different, but there is a trend towards overall survival with the trans-thoracic approach. But trans-thoracic approach have a morbidity, but now with the advent of this minimal invasive surgery with laparoscopy or robotic, that confusion has gone. Now coming to the Siewert's type 3, so the standard of care will be the total gastrectomy with the D2 lymph node dissection. And very few scenarios we use a proximal gastrectomy, like there are now it's a lot of studies are upcoming on role of a proximal gastrectomy, because the lymph nodal status, when they analyze the chance of metastasis to greater curvature nodes were very less, and pyloric region was less. So very small set of tumors where the tumor is T1 and within 3 centimeters of GE junction and less than 7 centimeters length and no serosal involvement, you can go with a proximal gastrectomy. And Siewert 2 is a highly controversial area that differs from the West and East. The West go for a esophagectomy, whereas the East prefer to go for a gastrectomy. So when I analyze that, why there is a lot of differences in West compared to East is basically there is a difference in tumor biology and the surgical philosophy. Majority of the Western countries, the surgeons used to be thoracic surgeons. They prefer to go for a esophageal dissections compared to a gastrectomy, and lot of Western has a multimodality treatment of they included the radiation into their protocol. And of course the institutional expertise also is taken into this consideration. And not to confuse, so this is the finalized for the treatment for a Siewert's type 2, the esophagectomy. So mainly we do esophageal extension when there is a greater than 2 centimeters, and the pros is the complete mediastinal lymphadenectomy can be done, and maintenance the gastric antrum and physiologic food passage can be maintained. Whether a total gastrectomy, the main origin of the esophageal junction tumors is thought to be a gastric mucosa. So there will be a complete resection of the gastric margin can be done with this total gastrectomy. And this, I think last talk has mentioned this Japanese recommendations. So now the standard of care is depending on the how much extent of the tumor into the esophagus. If it is more than 4 centimeters, there is a very high chance of involvement of the mediastinal nodes. So this patient should go for a trans-thoracic esophagectomy. Whereas if it is less than 2 centimeters, they can go for a gastrectomy. That could be a total gastrectomy or a proximal gastrectomy. And takeaway is it's always the multimodality treatment for is mandatory for EGJ to adenocarcinoma, and type 1 will treat as a esophagectomy with 2-field Ivor-Lewis, preferably minimal invasive either lap or robotic. Type 3 is a total gastrectomy with distal esophagectomy through an abdominal approach. And there is no standard globally accepted surgical approach for type 2 tumors, but majority of our institutes, we follow total gastrectomy as the choice. Thank you.